Hello, everyone. Welcome to the Future of Human Health and Medicine Organization's second episode in our virtual guest speaker series. My name is Ryan Davis, and I'm a senior FHMO ambassador from Severna Park High School. Today, I'm excited to be joined by Dr. Stephanie Clements. Dr. Clements is a clinical dermatologist at Anne Arundel Dermatology. She attended Broadneck High School and graduated with honors from the College of William and Mary, where she also played on the women's lacrosse team. She obtained her medical degree from the University of Maryland School of Medicine and completed an internal medicine internship at Mercy Medical Center, followed by dermatology training at the University of Maryland, where she served as chief resident. Her practice focuses on medical and surgical dermatology. Thank you for joining us, Dr. Clements.
Thank you so much for having me, Ryan, and thanks for that wonderful welcome.
Sure thing. With that being said, let's start off with a presentation to learn some about the common conditions Dr. Clements treats.
So while he's getting that pulled up, I'm just going to talk to you all a little bit more about sort of what I do on a daily basis and some of the diseases that I treat. And some of them may be familiar to you, others of them you may never have seen before, but my hope is that you can take something away from the field after I talk to you guys, and I'm really excited to answer your questions as well. So here is my slideshow. So basically, the field that I chose was dermatology. And let's see if I can, oh yeah. So basically, one of the things that I treat really pretty much every day is acne. And I'm sure many of you have had acne, treated and things like that, but it's really common. I see a lot of teenagers with it, but I also see adults with it. And so, some mild cases, some severe cases, but that's something that is very kind of bread and butter, and I treat a lot of acne. And then psoriasis is another disease that I treat. So a little bit more rare, but typically it affects people's like elbows and knees and their scalp. And they just get really thick, kind of scaly, skin spots on these areas, and they can be itchy. And people are pretty bothered by these skin problems because oftentimes they're in areas where people can see. So like in the summertime, if you're in shorts and a short sleeve shirt, people may think, oh, that person has like a contagious rash or something like that. It may disrupt their social relationships. So it can be pretty distressing for patients. And, when you treat it and you clear them up, it can really lead them to a better quality of life. So that's something that I see a fair amount of, and patients are really happy to have this treated. And then eczema. So again, a pretty common skin problem that you've probably seen. It's pretty common in children. And then some people, have resolution of their eczema by the time they reach adulthood. But a fair amount of people have eczema throughout their life, and it can be a really kind of like intermittent chronic condition to have. It's super itchy. It usually affects people's like the creases of their arms and their legs. In babies, it can affect their face and their scalp. But really it can be anywhere, but those are the classic areas. And it's so itchy that it keeps some patients up at night scratching, and they wake up in the middle of the night kind of digging their skin. So like, again, if you can treat this and get them better, then it really leads to a better quality of life, and they can focus when they go to school, and their relationships are better. So it's really rewarding to be able to treat that as well. Rosacea is another thing that I deal with. People come in with like kind of like the rosy cheeks and rosy nose, as you can see in this woman here. And they have certain triggers, like they'll say, when I go out in the sun, it gets more red, or when I, drink a hot beverage or eat a spicy food, this tends to get more red and things like that. So a lot of it is just educating them on, avoidance of their triggers and making sure they wear sunscreen every day on their face, because sun can make this worse. And then we have a variety of medications we can treat this with. But again, pretty, socially distressing because it's your face. So you can't really hide that going out in public. So that's one of the reasons, and I'll get into it later, that I love my field, is because the skin is so visual. So people are so affected by these things on a daily basis in a very visible, kind of meaningful way in their life. So again, this is another example of something that I treat. And then this one, so this is a type of hair loss called alopecia areata. And on the left-hand side, you see this man who has lost kind of patches of hair. And what drives this disease is that the immune system kind of gets screwed up, where it starts to recognize your hairs as foreign, and it attacks the hair and the hair falls out. And so, there's a lot of different ways we can treat this. Not, some of them are effective, many of them aren't. This is one of the hardest things I deal with, especially the lady on the right-hand side without any hair. She's lost most of her hair. And that's really tough. And so some of these people have to resort to getting wigs, fake hair and stuff like that to try to just cover it up. But, this is a tough condition, especially for women who are, expected in society to have like long hair and things like that. So anyway, it's really rewarding when we can help these patients. And it's definitely a tough condition.
And Dr. Clements, do you find, like, are people born with alopecia, or do some people have hair for 20 years and then not have hair?
Great question. You can develop it at any point in life. Typically it's in teenagers is when they get this one, but it can happen at any point in your life. So that's a great question, but I don't think typically people are born with it, I would say. Yeah. So nail disorders. So because dermatology is dealing with hair, skin, and nails, we do deal with nails. So, on the left-hand side, you see probably a melanoma, a skin cancer growing from the pigment cells of the skin, the color cells, leading to this streak in the nail. And if it's widening, and, that's probably a melanoma in the nail, which is crazy, kind of rare, but really bad. And then this one on the right-hand side is just a toenail fungus, and you may have seen it, you may not have, but we need to treat that with an antifungal medication.
And so how would a patient know whether they should go see like a dermatologist or maybe a podiatrist for like a nail disorder?
Yeah, that's great. So great question. I think you could see either specialist for like nail disorders, especially on the, like, podiatry is for mainly the feet. So, it depends on if I feel comfortable with what I'm treating, and, if I feel like we're making progress. If I don't feel like we're making progress, and I feel like maybe podiatry could lend a different lens to something that maybe I'm not, familiar with, then I'll definitely send them to podiatry. A lot of kind of like calluses and corns and things like that on the bottom of the feet that maybe don't respond to like pretty straightforward treatments, I'll send them to the podiatrist. They have like better tools and different approaches to things on the feet. So it just depends. But I think in general, you could start with sending someone to a dermatologist for anything related to the nails or the skin. And then you could always forward, push them into a podiatrist if they're not getting better, need more care.
Okay.
Yeah. And then, so I deal with a lot of growths on the skin too. So benign, like meaning non-cancerous skin growths include like freckles, which is on the left-hand side, which we've all seen. These things called lentigo or lentigines, which are basically like sun freckles that you can get as you get older. So typically 40s, 50s, 60s-year-old patients, you'll see them have these like kind of light brown speckles all over their skin. And they're not like perfectly round like freckles like this, but they kind of look like bigger and kind of splotchy. If you look at your grandparents' skin, you can probably see these things. They're non-cancerous, but you just want to make sure you're looking at them as a dermatologist to make sure that none of them are like transforming into cancer or anything, and they'd get darker and irregular. But that's a whole nother thing I'll go into. And then this bottom thing is just kind of like it's like a waxy kind of stuck on skin growth called a seborrheic keratosis. And they're super common. People will come in with dark ones saying like, oh my gosh, I have cancer. And then I'll have to like reassure them that no, like these are totally non-cancerous growths, but they do come up as you get older, and you probably get more of them. So a lot of it is, some of my job is like differentiating between like bad players and good players like on the skin, and letting the patient know like, hey, you don't need to worry about this, or, oh, hey, yeah, you need to watch this, And then, so skin cancer. So basal cell carcinoma is by far the most common type of cancer in the United States overall, and it's the most common type of skin cancer. You see these kind of like, we call them like pearly kind of growths. They're kind of shiny. They have little blood vessels in them. I don't know if you can see the little red spots. And then that's a classic one, but then sometimes they can look pigmented, so they can look darker, but they're still kind of shiny. And then sometimes they're superficial, so they grow really superficially, but they like to grow outward instead of sort of up. And so anyway, these are all just different variants of the same skin cancer, but all of these would need a biopsy or a sample of the skin to confirm that they're skin cancer. And then they're usually really treatable. They're very lazy, slow growing. They usually don't kill the patient. They just sort of will grow there like a lazy cancer for years and never really go anywhere. But that said, if they're near like the nose or the eye, we need to treat them because they will eventually invade those structures, you know. All right, and then squamous cell carcinoma, another type of skin cancer, a little bit less common than basal cell, but still pretty common. And this is a classic one, like you have this red kind of bump that's raised up, and it almost looks like a crater or a volcano in the middle of like kind of like skin debris. And so that's a classic picture of a type of squamous cell carcinoma. And again, that needs to be sampled and that needs to be treated. And then maybe you've heard of this before. You know, this is probably the worst type of skin cancer you could have. It can be fatal if not treated early. It's called a melanoma. So this is where either a new spot comes up on the skin that was never there before, or an actual mole that you had on your skin for years starts to change and become cancerous. So you can see over here, you know, it's very irregular. It's not symmetric. There's more than one color throughout them. It just looks like, okay, that's something wrong with the skin. You know, that's something is not right here. If you looked at the rest of the patient's moles, you're like, well, everything else looks round and symmetric, but this just doesn't fit the pattern, you know? And that's when you know you have a melanoma, usually. And then I'll go over the next slide. So this is a slide, this is a handout I give all my patients at the end of their visit. I don't care what age they are. If I do a skin check, I give this handout to them. Basically, it's the ABCDEs of melanoma. So essentially, it's a mnemonic to remember the warning signs of melanoma, which include asymmetry, border irregularity, color change or different colors within it. Diameter, what I say, is bigger than a pencil eraser because that's easy to remember. And that doesn't always fit, right? Some people have bigger moles, bigger than a pencil eraser. It doesn't always mean you have a melanoma, but these are all kind of features to keep in mind. And then evolution. So if you saw like, oh, I had this mole for years and then now it's getting bigger, it's changing color, those can be red flags, you know, to being a melanoma. So you need to come in and get that checked out.
And so usually when melanoma is discovered, is it by the patient or, you know, by the physician?
Yeah, that's a great question. I would say kind of equal in my experience, like I would say half and half. There's a fair amount of people that say either I noticed this mole changing or my significant other saw on my back this dark spot that they thought was changing. And then I look and it's a melanoma. But then there's a fair amount of patients that they never looked somewhere, maybe under their arm or whatever. And I'm looking at all their skin and something catches my eye and I find it. So I would say it's about half and half, but yeah, that's a great question. I don't know, like on a global scale, like in terms of all dermatologists in the country, like what's normal in terms of how many the patient discovers versus the doctor discovers. But for me personally, it's been about, I would say 50-50 or so. Okay, so I also do procedures, which I love. And I know this is one of the questions you were going to ask me. I actually focus more on like surgery and taking out like cysts or skin cancer or, you know, even non-cancerous growths. But I like that aspect of derm. There's a fair amount of people also that are really focused and passionate about cosmetic dermatology, where they'll inject Botox, they'll inject filler into people's faces, and they'll improve people's appearance, like with lasers and things like that. I'm more on the side of like treating medical medical diagnoses and medical treatments for like cancer and non-cancer, not so much the cosmetic side of things. But you can definitely pursue both or either one if you go into dermatology. But anyways, Dr. Pimple Popper, I don't know if you've ever seen her show, but she does some pretty intense surgeries. I do some of the same things she does, but probably on a smaller scale. She tends to do the biggest cases of everything because it's really dramatic for the show. But I thought that was a good thing to include just because to kind of get an idea of like some of the things that I do. So this is like a routine thing I'll do pretty much. I'll do 5 to 10 of these every single day when I go into work at some point throughout the day. But skin biopsies. So a biopsy is just sampling of the skin. And what that allows the dermatologist to know is that basically they want to see what that spot looks like under a microscope on a cellular level. And they want to have a confirmed diagnosis of, is this a skin cancer? Or is this not? Or what is this rash? Can you tell me the pattern under the microscope? So a skin biopsy is very helpful to get more information. And I think the beautiful thing about our field, which I think is unique to derm, is that the skin is so accessible. I don't need to put my patient to sleep. I don't need to go in doing a scope to get inside, the GI tract or the heart or, other organs. I literally have the skin right in front of me. I can numb it up like you're at the dentist kind of with that. It's kind of like Novocaine, it's called lidocaine, but basically they're cousins of each other. I just take a little needle, I numb up the area. It only takes a second and the patient is numb in that area. And then I just take this blade and I basically shave it flush with the skin. And the way I describe it to patients is I say, it's almost like you nicked yourself with a razor shaving. And basically that's the wound that they're left with, which is not a big deal. And then it heals up in a little bit, a week or two or so. And then by that point we have the results. And I tell the patient, hey, that thing was nothing. It was non-cancerous, or, hey, that thing was a basal cell or a squamous cell. We need to do some more surgery. And then I bring them back and do more surgery. So that's kind of in a nutshell, like the whole biopsy thing, but that is a very common practice for me on a daily basis. Yeah.
And do you do the pathology in your office, or do all your samples get sent out?
All of our samples get sent out. We have really great pathologists who their whole day is spent looking under the microscope at skin samples like this and confirming things. And oftentimes we'll call them and we'll have discussions with them about certain things. If anything's a melanoma, they always pick up the phone and actually give me a call and say, hey, Mr. Jones has a melanoma. So I know I can act really fast on that. Whereas other things, they'll just send a report and I get it faxed over. So the reports usually take like 5 to 10 days to get back, but yeah, pretty quick turnaround. So yeah. And then punch biopsy. So I use this when, let's say I'm looking at a rash that I don't know what's going on, or certain other skin conditions are really helpful to get more tissue. So instead of just taking that superficial shave, I kind of go deeper with this punch tool and get like a kind of like a cylindrical sample of the skin as pictured right here. And same idea, I numb it up, I take this sample, and then I didn't show this part, but basically because you're left with this like kind of like little divot in the skin, I need to take stitches, and I just take a stitch from here to here and here to here, and I just close it. Like it'll just be like a little line of stitches, like just 2 stitches. It's very small. And then they get the stitches out in like about a week or 2. So pretty quick. Like I said, it's very accessible for me to do a biopsy like this, and I do a fair amount of them. Okay, and then this is the final slide. So this is what I was talking about when I say I do surgeries. So same idea, but like, let's say over here on the left, this is a skin cancer. Basically we draw a margin of normal skin around the skin cancer tumor. And that is to ensure that we get all of the skin cancer out and all the margins are clear at the end of the day. So I draw that circle, but then I have to draw a bigger ellipse around that, because if I closed a perfect circle on itself, it would just buttonhole and look really bad in terms of the scar. So I have to cut out a larger piece of tissue just to make sure that scar lies flat like this on the right. And this is a picture of a surgeon taking out, like with the scalpel and the pickups, taking out the skin. So it's amazing. I love surgery. I feel like I liken it sort of to like cooking in a sense, because you have to follow a procedure, you have to follow the steps, you have to, you have all your tools, you have a really nice result at the end of the day, you're leaving the patient with a nice scar. You just feel a sense of accomplishment being like, I just took out this person's skin cancer and I left them with a good scar. So I love surgery. I think when you do med school, you'll figure out whether you like a lot of surgery or whether you'd rather kind of think about all the diagnoses and treatments and like brainstorm and read and be more, I don't know, not academic, is that the right word? But I think there's 2 different types of sort of flavors of doctor. And I think I lean more towards the surgical type. But again, you can be a mixture, and that's the beautiful thing about medicine. You can do a little bit of everything, but I love surgery personally. So yeah, hopefully that was helpful.
Absolutely. And so would you say, like, when you chose to do more surgery, is that more of like formal training, or is that just like sort of informal, you just prefer to do these cases?
Yeah, great question. Yeah, so I didn't undergo any further training. So in my dermatology residency, which I can get into a little bit, I probably did 500 surgical cases before I graduated under supervision at first, but then you have like graduated supervision. So just like anything else, I'm being watched and taught really aggressively at the beginning. But as I've done more and more cases, I can just kind of do them, and the supervisor would kind of pop in, oh, are you doing okay? Look at it. Okay, leave the room. And you're kind of doing it by yourself. So after a while, you have like graduated responsibilities. But to answer your question, no, like everybody to do dermatology residency like has to mandatorily do a certain number of surgeries in order to graduate. But then I guess now that I'm out of my training, I could choose, oh, hey, I don't really like doing surgery. Let me leave that to someone who loves doing surgery. Let me just do, general dermatology with no surgeries. And that's kind of up to me. But like, because I like it, I do treat a lot of my skin cancers myself. So.
Okay, awesome. And so could you sort of give us like a day in the life of a dermatologist, like when your day starts, what kind of cases you see,
Yeah.
things like that?
Yeah, sure. So, like typically, my first patient would be scheduled at like 8:30 in the morning. So I get in and, I have an iPad. So I like get my iPad all loaded up because that's where my charts are and everything. So it's all electronic. And then I have like medical assistants that help me like they'll write my notes or at least draft them while I'm in the room with the patient. So I can like focus on the patient the whole time while they're kind of typing and getting all the details down, which is really nice. But they also assist with procedures and stuff. So they'll come in and they'll say, okay, your first patient's here. They're here for acne. They tried this, it didn't work. Or, oh, they're on this and it's working really well. And then they kind of give me like an overview of the patient before I even enter the room, which is really nice. And then I go in the room, I see the patient. I usually see each patient for about 15 minutes. If it's a surgery, I have about 45 minutes with them. So 15 minutes is a nice amount of time to ask them a couple questions, like kind of have like a little chat, but then also have enough time to like look at their skin thoroughly, and then have enough time to counsel them about the diagnosis and the treatment, which is super important, and give them time to answer or ask me questions as well before they leave. So anyway, that's a 15-minute sort of visit. And then I just pop out of the room. I try to quickly finish my note if I can. Most of it's already written because my medical assistant helped me do that. But I want to add some details here and there. And then, the next medical assistant is up with the next patient when I come out of the first room. So then I have to go into the second room, and I kind of just alternate rooms all day. 8:30 in the morning I start, I end right around noon before lunch, and I have like an hour lunch break every day. Unless I'm slow and I am behind, then I get less of a lunch break. But usually that, and then at 1 to like 4, I think my last patient's at like 4:15. So I'm done with clinic by like 4:30, 4:45 or so. And there is some work outside of work where you have to like call back results or look stuff up or, different things. But, globally, I try to be out of there by like 5:15. But, that changes. Sometimes they'll be earlier, sometimes they'll be later. So, and it's Monday through Friday, but most dermatologists, because it's a great specialty, get 4 days a week being full-time. So I do just work Monday through Thursday. But I have long days and I work really hard when I'm at work, but I also have a good work-life balance, and I'm off. I have a 3-day weekend every week. So it's really nice, but that's not always how it was. But now that I'm out, it's much better. So
Yeah.
yeah.
So how did you know that dermatology was right for you? And like, did you figure it out in
Mhm.
medical school, or did you already go into medical school thinking you enjoyed dermatology?
Right. Yeah, so I didn't go into medical school knowing what I wanted to do. I had a couple ideas, but I really wanted to like take it all in and like learn everything and be like, oh, what do I love, or what do I really wanted to know that whatever I chose, I really loved, and like I'm passionate about it. I want to help these patients. So I kind of just went into med school with an open mind, but I did have really bad acne growing up myself, and so I just remember how big of an impact my dermatologist growing up had on me. And that was one of the few doctors that I like really saw growing up, because I was healthy and young and everything. So, but she was like so nice and really cleared up my skin, and it like made a huge impact on me. So I always had that in the back of my mind, but I wasn't like sure that I wanted to be a dermatologist. But then as I went through all my rotations in med school, which consist of kind of like spending time in each specialty as you rotate for like a month or two at a time, I was like, oh, maybe I'll be OB, like maybe I'll deliver babies and like deal with that. Or, oh, like maybe I'll be a surgeon and like take out gallbladders and appendix or whatever, and I had all these thoughts like emergency medicine's pretty cool. And, but then as I went through, I realized like I was happiest during my dermatology rotation because I just really identified with like the whole thing, like the diseases, the treatments, the patients, like they were young, they were old, they had acne, but they also had skin cancer and they're like 80 years old, and I could do some surgery, but I also am not like in the operating room having to glove up and, put my patient to sleep and have all these huge risks. Like I literally can do the surgery while they're awake, talking to them just under local. So it was just like the best. I felt like it was the best of like a lot of different specialties in one. So anyway, I know that's a long-winded answer, but I fell in love with derm and I've loved it ever since. I really can tell you, like, obviously you have hard days in life and any job that you work, but I really truly love what I do. So I'm really thankful for that. And it's such a blessing. So
Awesome.
yeah.
So for you, a surgical dermatologist, what sort of overlap is there between, like, say, you and a plastic surgeon, and how would a
Yeah.
patient know, which physician they should go to?
Sure. Yeah, that's a great question. So, plastic surgery has like sort of, so there's a lot of overlap between us and plastic surgery. I think they have different like training and sort of like a different lens to look at similar things, if that makes sense. So, plastic surgery, I would say globally, their focus is to improve people's appearance, I would say. So, and correct me if I'm wrong, if anybody has like family members in plastic surgery. But and I mean that from a perspective of like, say they had like deforming breast cancer and they needed like a lot of their breasts removed, or they were in a car accident and their face is deformed and they need to be reconstructed and make sure that the skin all fits, correctly and it looks really good or the best that it can look, or a bad dog bite or something. That is going to go to a plastic surgeon because they specialize in like sort of reconstructing the skin and making things look aesthetically pleasing. Whereas I think with dermatology, we focus more on taking out like skin cancer and medical kind of focus. Not that they're not medically focused, but I think they take out more non-cancerous things and they focus more on the reconstruction. So there is some overlap, and I think at least in my mind, when I have a patient that I know is more cosmetically sensitive, like let's say they're very focused on their physical appearance and they, every single scratch mark or scar is like a huge deal. I'm like, let's send you a plastic surgeon. I'm not going to touch your face with my scalpel. Like, I would rather have you have someone that, is going to focus on that and be like, the best of the best in terms of the cosmetic result. Not that we aren't as dermatologists, but that's like not our primary focus. Our primary focus is to take out the skin cancer or to deal with the, that problem.
Right.
So, I guess that's one way of answering it that probably may make sense. I don't know if that helps, but
No, yeah, absolutely. And so you said,
yeah.
while you don't work in an operating room, like, do you see all your patients in like the clinic or in a hospital setting?
Yeah. So they're all in a clinic. So they all come in, they sit in my, they'll come in my room. I will, evaluate their skin, discuss treatment, and then they leave. So they're healthy enough to be able to like walk into the office, come see me and leave. Whereas like other doctors, which I'm sure you've interviewed before, maybe the hospitalists, right? They have patients where they're like literally in a hospital bed and they're staying in the hospital overnight. And those tend to be like sicker patients that can't be at home and just come in for a visit. Do you know what I mean? But my
Right.
patients are healthy enough that they can like come in and leave and they're fine. So I think that's a plus. I really like that. Some people love like the sicker patients. My husband is in cardiology and he loves to deal with like sick patients in the hospital, and that's like his thing. For me, I love, not that I don't love taking care of sick patients, but I think my like passion is taking care of healthier patients that they may have really bad skin conditions that I could treat, but it doesn't mean that they can't come into the office and leave and kind of, they're healthy enough to do that, I guess, if that makes sense.
Right, right. And you
Yeah.
sort of hit on it earlier, sort of talking about how, some things are more cosmetic than others, and how, it can
Right.
be more of, embarrassment or that sort of thing, with certain skin conditions. So how do you find that, dermatological treatment helps with people's like, their mental health and those sort of
Oh yeah, yeah, absolutely. Well, that's one of the things that I'm so like happy that I'm in this field for, because I know, at least in my own experience personally with my acne, and I know a lot of my patients as well, like with various skin problems, it is so visual and it's so out there that people will like judge you for having anything on your skin. You could have a rash, you could have acne, you can have, you know, a growth, whatever it may, like people have like a big mole on their face or something that, you know, everybody, it draws attention to you when you walk in a room or whatever, and people feel self-conscious about it, and it affects their life. And even beyond just the physical like appearance aspect, just the symptoms aspect, if you have like eczema or psoriasis and you're itching up a storm, you're flaking everywhere, you know, your scalp is all flaky, like not only is it embarrassing, it's like frustrating because you're putting on all these creams every day, it's not working. You know, you're just, it's just frustrating. And so if I can do something to help like those patients feel better, get better, clear their skin, it is like, it's so fulfilling. Like it's like the best thing ever. And it's often, I mean, oftentimes it's hard. I mean, I'm not going to lie and say that there aren't some tough cases where it's like, I've tried everything and, you know, these people aren't getting better. Other cases are total like success stories, and they come in, they look clear, and they're like, I have a better life now. Like, I feel so happy, you know? So I just think like it can be pretty dramatic to see people's skin clear up, and it's very like, it can be emotional for patients. It's very much, it has a role in their mental health. And so if I can do anything to help that, it's like, it's such a win for me, you know?
Yeah, absolutely.
Yeah.
And so do you have any like most memorable cases that, you'd be able to share?
Yeah, that's a good question. I'm trying to think. I'm trying to think of a good example. I have a couple of them. Yeah, I mean, I think one case I had, this person, this like teenager had such severe scarring acne, like literally like really deep, painful, like acne on the face, the chest, the back. Literally wouldn't even like look me in the eye the first visit because they were so ashamed. Like they just felt so bad about their skin, you know, and I was just like, oh my gosh, their self-esteem is so bad. And I felt so bad, you know, for them. So we started to work with them. We did Accutane. I don't know if you guys have heard about Accutane, but it's like the one medicine and acne treatment that's, it can be strong. It's strong, you know, but it's like a 6-month course where afterwards people have like pretty much almost complete or complete cure for their acne. So we put this guy on Accutane, and he came back, and every month I could just see his mood and his spirits were lifting because his skin was getting better. And finally, you know, he was pretty darn clear at the end of the 6 months, and he stayed that way even after stopping the medicine. And, you know, he started to be more interactive with me at the visits. He would be like, oh, hey, you know, he would talk to me about school. And whereas at the beginning, I could see he was so depressed, you know, and it was just like, it was life changing, you know, and I think it just made me so happy to see him get better and to see him be able to live like a different life. I think he was like, I've never gone to like school dances, and now I'm going to go to like my prom and stuff. I mean, it's just life changing, you know? So it's like, I can't even put a price on that. It's like, that was one of my most memorable cases because I remembered like how sad he was at the beginning and just how much it made him feel better, like at the end of the treatment. So anyways, it's cases like that that like keep me going. And it's really like motivating to, you know, definitely keep treating patients like that. So
Yeah, that's awesome. I think, a takeaway is like, dermatology isn't just about, the physical condition, it's how you feel and
yeah,
how you feel around others. So,
exactly.
but at this time, I'd like to start doing some viewer questions. So someone asks, what is your favorite acne treatment medicine?
Oh, so that's a great question. So like there's different like tiers of like different levels of medicines that I use. So like I guess if you had to ask me favorite, I would say like the medicine I just described was just Accutane. I don't use it on everyone. I use it on like the more severe cases. But that would be my favorite medicine because that's the one where I see the most dramatic improvement in people's skin. And realistically, like most people have like a cure from it. So that makes me the happiest to use, only in the right patient, obviously. But yeah, there's different levels. So you start out with just topical creams and washes, and then you go up the ladder, and you could do like a short course of an oral antibiotic pill that can kind of calm things down in your skin, and then you can go up to like Accutane, if you need it. So those are kind of like the levels, but I would say Accutane is like my favorite medicine, but it's not for everyone, and it's only for more severe cases, but I like how much improvement it can have. So.
Okay. And so the next question is sort of about residency, and that is, since dermatology is a very competitive specialty, what advice would you give to those aspiring to be a dermatologist? Yeah, and I think another thing to add is like, what can you do to sort of stand out to residency programs to get into a very competitive one?
Okay. Yeah. So, I mean, I guess the first part is like, what is residency like, right? You said, you asked me, or
Right. Yes, that's
what
correct.
is residency like? And then I'll go into like what you can do to set yourself apart. So yeah, residency. So medical school is 4 years. And then after that is residency. And like for dermatology, it's like 4 years. So it's 1 year of general medicine. So kind of like I was literally in a hospital actually, like working with pneumonia patients, asthma attacks, like chest pain, just not even like skin, just like literally just bread and butter, like medicine. And that's mandatory for everyone that wants to specialize in dermatology. So I completed that year, which is very different than what I do now. And then the last 3 years are purely dermatology. And that's like hands-on training as a doctor, just under supervision. So that's 4 years. And then you ask like, what can you do to set yourself apart? I think getting involved in whatever department you are interested in early can really help. So like I spent time in the dermatology department. Even when I was in med school, I would like go to their meetings and like meet the people that, work in that department and kind of like, show my interest. I would volunteer my time to, help write articles and stuff for the residents that were currently there. So just different things to show like that you're interested and that you're present and you're willing to work hard can really set you apart. The other thing is, I mean, unfortunately, like grades and some numbers can help set you apart. That's not the only part of the portfolio that they look at, but that can help as well. But I definitely, personally, I really focused on like my personal relationships with people in the department and with the patients and trying to volunteer my time and get involved. And I think that went a long way. So.
Okay. And so, what is something that you would recommend everyone do to improve their skincare?
Oh, great question. I would say wearing sunscreen every single day of the year, specifically on your face, because I know no one's going to lather up in sunscreen on their whole body every year, every day of the year, in the winter and on rainy days, but on your face, it really pays dividends. I see people that have worn sunscreen their whole life and they look 20 years younger when they're 80. And it's because wrinkles and sunspots and all of that stuff, it happens from cumulative sun exposure over your whole life. So, and obviously you're preventing skin cancer too. I know for those that wear makeup, a lot of makeup products have sunscreen naturally built in. So that's a really nice feature. Just making sure that it's SPF 30 or above is ideal. But just putting sunscreen on every day, even if it's in your moisturizer on your face. In terms of skincare, I think just general practices would be just moisturizing your skin regularly, especially in the winter months. So I personally like Eucerin as a brand. I like a lot of the different brands, but the Eucerin like advanced repair cream is really nice. I actually have some upstairs by my bed and I just like put it on my arms and legs before I go to bed every night, especially in the winter, and it helps like moisturize. Especially with the COVID, I've been like washing my hands a lot, so that's helpful. So I think just keeping moisturized and also wearing sunscreen would be the two things that come to mind. And you can probably ask me more specifically like acne and facial stuff that you can do to like prevent wrinkles. But I don't think you guys are there yet because you're in high school. So.
And we had a question in the chat, and it is sort of relating to sunscreen. Does
Yeah.
oversun exposure cause melanoma to happen, or is it natural?
Yeah. Good question. So sun exposure absolutely causes melanoma. It's a risk factor for melanoma. So the more sun exposure you have, you're increasing your risk of melanoma. But just like smoking and lung cancer, not everybody who smokes will get lung cancer, but those who smoke have a higher risk of getting lung cancer. So it's the same kind of phenomenon. The other thing I have to mention is melanoma is very genetic as well. So if you have a family member, specifically a primary relative, like a mom, a dad, a sibling who've had melanoma, then you're at higher risk of having melanoma yourself in your lifetime. So sun exposure, the genetic part of things, and those are the main two things. But like sunburns, tanning bed use, those are all bad things that can cause melanoma. If there's another thing I should say to you young people, and I wish someone had told me this as well. Tanning beds are really bad, and it's bad. I see young people with melanomas that are using tanning beds, and they would have probably never gotten them if they're not repeatedly exposing their skin to these things. So just remember that. I know many of you might say like, oh, I just do it before a wedding, or I do it before, like, I go to the beach just to get like a base tan, but it's just exposing your skin to UV rays, and it's creating DNA damages in the skin that are, could eventually lead to skin cancer. So just try not to expose yourself to that unnecessary radiation, and don't believe those pamphlets that they say it's safe, because it's not.
Okay, awesome.
I'm very passionate about that.
I guess it's the best thing, to keep you from having to get, melanoma, cut out of your skin. So
Right. And if you like the bronze look, you can just get a spray tan, because you're not exposing your skin to radiation and all that.
So unfortunately, we're out of time for today, but
Okay.
Thank you so much, Dr. Clements, for taking time out of your day to talk with us about your profession. Do you have any sort of final words you'd like to leave with us?
Yeah, I guess just thank you for having me, by the way. This has been great. But I guess just like pursue your dreams. Don't let people tell you you can't do something. You can do whatever you put your mind to, and that's really, I found that to be true. And just find what you're passionate about and go after it. And I really think that will go a long way. You don't want to be doing a job that you don't love. I don't care what you do, but make sure you love it. Also, I'm going to leave my email with Ryan. So if you guys need anything or have any questions or just want to chat more, I'm more than happy to talk to you. So just reach out. Okay.
Thank you, Dr. Clements.
Thank you so much.
You're welcome. And to everyone watching, please stay tuned for our next guest speaker event. Thank you again to all of our viewers, and have a great evening.